So here we have a tooth that's tender on percussion, as you can see. The patient is wincing in pain when it is tapped. So whenever we're going for a root canal, it's important to do a thorough initial diagnosis, which involves both the clinical picture as well as the radiologic picture. So over here, we're just going to make an appropriate radiograph of the appropriate area where the patient is having pain. And as you can see, there's definitely a periapical lesion associated with the tooth where the patient is complaining about pain. So once we've seen the lesion, we want to go on and we want to have a proper isolation from the saliva and other oral fluids. So it's important to do the rubber dam prep. So here we're just using a rubber dam sheet and we have a rubber dam template where we're just marking the appropriate teeth in order to make the appropriate punch holes and subsequently place the rubber dam in the patient's mouth. So right over here, we're just going forward and we're going to punch the rubber dam. All these rubber dam punches, they have multiple sizes of punches. So we want to select the appropriate one. And over here, we're just using 2 premolar clamps. Since we're going to be treating an incisor, sometimes it's easier just to clamp the premolars. That way we have a good area of access. So as we can see over here, we have the rubber dam all set up in the patient's mouth with the premolars being clamped. It's important with respect to the clamps to have some floss tied to them just for our safety and convenience. So once we have the floss out of the way, we can put some wedgets in just to get a clearer access of the tooth in question. And over here, we are starting with the access opening. So in this particular case, the tooth is non-vital, so we don't need to go for a local anesthesia, but otherwise, in the case of a vital tooth, it would be important to go for local anesthesia initially so that the patient is comfortable and doesn't feel pain during the procedure. So here we're just going for the initial filing just to get a working length. So over here we're just using a number 8 file along with an apex locator, an electronic apex locator that gives us a good idea of where the tooth apex is. It's important to use a small size file to do this so we don't end up transporting into the periapical areas. We should confirm this radiographically as well, as is being done here. Once this is confirmed, we can start with larger filing with the greater taper files. So over here, we're starting with the filing. We can use either an endo block or, as is shown here, we can use an endo ring to make the appropriate measurements. And we're just going through with the filing until, in this particular case, a master cone size of maybe 40 number file. So it's important to use the watch winding motion when we're doing this, and it's important to use good quality files that are free of any kinks or bends so that we have been able to file clearly without any risk of sort of a fracture of a file or separation of an instrument, etc. And we're using EDTA jelly just to help us negotiate and lubricate the canal as we file it. And this is a syringe full of saline that is being used to irrigate. Multiple irrigation solutions are available. In this case, because there is a large periapical lesion, we don't want to irritate those areas, so we're not going for something like a hypochlorite. We're specifically going for a saline solution. It's important that with each filing, we keep irrigating nicely with the physiologic saline. Over here, we just have a paper point that we are using to make sure we dry the canal. And because we do have a very large periapical lesion, we're going to use RC-Cal, or our calcium hydroxide solution. This is a solution in an aqueous base. And so we're just going to place this on a file, and we're going to insert this file to working length. We want to make sure that we don't force the solution periapically, but we do want to get it thoroughly into the canal and coat the surfaces of the canal such that any sort of lingering fastidious organisms are more likely to be eliminated and prevent infection further on down the line. So once the solution is placed, we can use a temporary restorative material. Over here we have T-Fill by Mark, but there's also other options available, such as Cavit G, that can be used to temporize the tooth. And of course we should use cotton or Teflon as a medium prior to placing the temporary material so that it does not go deeper into the canal, where it would be more challenging to remove. And after this, we can just carefully dismantle the rubber dam system, making sure that when we're removing the wedgets, if any are used, that we do so gently, because it can be quite painful and uncomfortable for the patient. So there we are. The patient can go home for this time with some medical prophylaxis, and then recalled in 10 days. Over here, we're just removing the temporary again, and we're just clearing out the small pieces of cement. We had used some Teflon, so it was quite easy to remove the temporary material without too much of residue being left over. And since we had previously placed the calcium hydroxide, we're just going to irrigate nicely with the saline and then go ahead and obturate. Initially, we're going to take a master cone radiograph. So since we have filed master cone till the size of 40, we're going to use a 40 number GP. And here we've taken the radiograph as before, just to confirm that our master cone is indeed reaching till the apex. Here, maybe we can nip about 0.5 mm off the end of the master cone before we go for the obturation. Now, prior to us going for the obturation, it's important to again use paper points to dry the canal. And once that is done, we can use an appropriate sealer. In this case, we're using AH+. There's multiple types, such as resin-based sealers or bioceramic sealers. So you can go through, we can seal the canal. Here, as you can see, we've used lateral compaction to properly compact the canal because it is quite a wide canal and we had prepared it by step back. So we've placed multiple cones to get a thorough seal, especially a thorough apical seal of the tooth in question. And here we're just using an obturating pen to melt off and remove the excess GP. Of course, we can do it with a manual pair of scissor-like devices as well, but this allows us to go slightly into the prepared space and get a cleaner cut. And again, we've temporized, so as we can see the obturation.